دكتور محمد، ازي حضرتك يا دكتور محمد؟
يا اهلا وسهلا يا دكتور احمد، ازي
لا، ازي
حضرتك؟
حضرتك؟ يا صباح الخير عند حضرتك دلوقتي، صح مش كده؟
الساعه 11 دلوقتي الصبح.
احنا عندنا يعني مساء الخير عند حضرتك بقى صباح الخير. اهلا وسهلا. دكتور محمد، يعني انا اتشرفت ان انا سمعته قبل كده في اول مؤتمر للاي دي كير، وكمان دكتور محمد انا اتشرفت كمان ان انا بقى يعني كنت تلميذ وسمعت له في محاضرات الزمالة، يعني فمش عارف هو اصلا يفتكر ولا لا يعني.
ربنا يخليك. لا افتكر طبعا، وفاكر الدكتوره هي اللي رتبت المحاضرات، فاكر كويس جدا يعني.
احنا سعداء والله بحضرتك
ده انا
دكتور محمد.
الاسعد، انا الاسعد والله.
جزيل الشكر على قبول الدعوة يعني.
العفو
آه،
العفو العفو،
الله
لا العفو.
يخليك والله دكتور محمد، أنا إكسبرت في الانفكشوس ديزيز، اسوشيت بروفيسور دكتور محمد في بيتسبرج بنسلفانيا. المستشفى اسمها UPMC ميرسي. دكتور محمد تمام كده؟
مظبوط مظبوط.
آه. إن شاء الله يعني الموضوع اللي معانا طبعا يعني as many of you may know يعني dialysis life saving treatment للعيانين اللي معاهم end stage kidney disease، لكن هو برضو مع كده puts patient يعني at high risk of infection due to frequent use of catheter needles، كمان other medical equipment يعني. الموضوع اللي معانا إن شاء الله we will explore the most common healthcare associated infection in dialysis patient مع risk factor associated with them and the best practice for prevention and management of them. So join us for this informative and insightful discussion with Professor محمد. بالتوفيق إن شاء الله دكتور محمد. حضرتك ممكن تبدأ.
كتر خيرك، شكرا جدا. انا متشكر على يعني ال very warm introduction
لا لا العفو يا دكتور محمد.
لا والله بجد. انا
بجد
يعني
فعلا.
انا كل مره بقى الدكتور مصطفى او انت يا دكتور احمد، الدكتوره اماني، الدكتور احمد سعد الكبير، وكل الناس بيطلبوا مني او بتشرف ان انا اقابلهم. انا بحس بسعاده كبيره جدا، وبحس ان انتوا يعني بتشكروني وبتقولوا عليا حاجات كويسه، وانتوا اصلا الابطال، وانتوا الدكاتره المحترمين العظماء. احنا ناس على باب الله غلابه يعني.
العفو يا
بس
دكتور
بس let's get into the topic. يعني انا I do believe that dialysis is an area that infection is really, really very important. And unfortunately, infectious disease physicians, medicine, internal medicine, others are not that involved. Usually the nephrologist takes care of A to Z from those patients. And that puts us into a lot of issues. So I will focus on some of the clinical issues that you guys are interested in, but I will also focus on stuff that I feel you may have not thought about, and maybe it's important, and maybe infectious disease doctors like yourselves would be interested in actually taking a role in infection prevention and actually directing this patient to be safer, not only as a tertiary care to treat them when they get infected, but probably to prevent them from getting ones. So let's get in. So the first step here to know, is dialysis patient or end-stage renal patients or chronic kidney disease patient, whatever the term is, CKD will be chronic kidney disease, end-stage renal disease will be ESRD. Dialysis will be either HD like hemodialysis or PD, which is peritoneal. I'm just trying to make sure that you guys are not lost in those abbreviations that I'm making up as we go. But do we have any disagreement that dialysis patients have lowered immunity? Their immunity is not intact as an average person. I think we all agree on that. And we don't know how to quantify lower immunity or immune suppression very well, but we know there's a lot of things in those patients make them more liable for infections. As part of that, I'm saying when we talk about antibody production, we know they don't respond to vaccination very well. We know that. So we know that when they have an infection, they're not going to phagocyte the infection well. They're not going to produce enough antibodies. We know that their T cell function is not working very well. We know that the toll-like receptors and the antigen-presenting cells are not really working as good, so they don't identify the pathogens. They don't immediately kill them. And we also know that it's almost like a pro-inflammatory stage with a higher C-reactive protein and a lot of inflammatory markers. And I remember this last one that I put a exclamation mark, changes in microbiome. So as Dr. Mustafa Al-Fishawi, who says he's my student, and I do think I'm learning from him more than he's learning from me. So Mustafa, when he was an ID fellow at the University of Pittsburgh, we were working on septic arthritis project, and he was very interested in every time to talk about the bacteria or the microbiome of the person makes them really, that's what makes them get the immune-mediated reaction, rheumatoid arthritis, other stuff like that, and also make them susceptible to infections. And my disagreement with Mustafa then is, I actually agree with him, and I think he's a genius, and I think he's right, but we don't know how to prove that. We got to show people how to prove the relationship. But now, maybe 10 years after Mustafa, everybody's talking exactly what he's saying and trying to make the links between many of the infections or many of the immune-mediated reactions and the microbiome of the person. So without any doubt, we know that there is a microbiome that is very different in dialysis patient as compared to the general public. And we're not sure exactly how is that predisposing them to infection, but we think it does. I'm going to skip that one because I'm really not interested in taking you into a basic science lecture. I'm more interested in getting into more, but the slides could be yours. I can send it and you can review as much as you want. Now, this information is from the CDC. I didn't make this up. So how many dialysis patients is dependent on the pool of diabetic and hypertensive patients. So on your right lower corner, you see 1 in 3 patients on dialysis are actually diabetic, and 1 in 5 are hypertensive. So that means their kidney was predisposed by this disease. That's really what got them into dialysis. Those are the 2 most common enemies that we have. In Egypt, as in the US, as in probably all the world, diabetes and hypertension are extremely prevalent. If we're thinking of prevention, we got to think, how can we get these controlled, taken care of to prevent this terrible outcome? Then when we say that, how many people have chronic kidney disease in the United States? And I'm really not sure if that number is the same in Egypt, but I bet it's going to be even worse. So they say around 1 in 7 adults have chronic kidney disease identified as elevated creatinine. And in the US, close to 1 million person on dialysis, close to 1 million person with end-stage renal disease, and the majority of them are in dialysis. And actually, the overwhelming majority in the US are hemodialysis. And the waiting for kidney transplant the list is massive, and the wait time is around 3 to 5 years. And I know in Egypt that may be a little bit better than here. And at the end, this is a very costly disease with around $50 billion cost from Medicare in the US. It's not a secret that when you have dialysis, you're liable to infection, you're liable to go to the hospital, and you're liable to die. I guess everybody knows that. That's not a discovery. But what exactly going on with those patients? Where is the infection that makes them so sick, make them get into these things? I think the most important is their access, and then probably going to bacteremia, endocarditis, vertebral osteomyelitis, significant sepsis, all the above, but it's their access. The second, which I'm really gonna overblow or make it bigger than what it should, because I really think we're not paying attention to it, the dialysis water-related infections, and obviously the relationship between the TB and the kidney failure is very well established. So I want to mention something about that. I want to quickly get into hepatitis B and C. And I want to mention quickly this, but I'm not going to mention it again. When you have diabetes and you end up with a nephropathy and kidney failure, you probably also have vasculopathy and neuropathy and retinopathy and other things that makes you more liable for getting more complications from the diabetes. So most of the patients who end up having amputation or vascular grafts or anything related, are probably on dialysis already. And then we're going to mention something quick about the C. diff relationship to dialysis as well as MDRO. So this data is from the national kidney data from the US, and you could see that transplant in the green line sounds like a very good thing to do if you want to reduce the rate of infection in these patients. It makes sense. And on the right side, you still see with the adjusted data that dialysis works very well. And obviously, once you get end-stage renal disease, either you're on dialysis or not yet, it's pretty much the same. You're going to be in trouble, and you're going to end up in the hospital quite significant number of times. This is a very interesting slide, and I would be really, really interested to hear from you what's your experience too. So take a note of this slide. That's slide number 7. And now or after the talk is done, please let me know what do you think. But in general, the overwhelming majority of the dialysis patient in the US, they start with a catheter. Despite the fact that we always say if we predict that the patient is going to have impending or late end-stage renal disease, they should get a fistula and let it mature, so they start on a fistula rather than dialysis with a catheter. And obviously over time, as you can see, by maybe a year or 9 months, the overwhelming majority, actually over 50% of those will end up having a fistula or a graft. And then when you look at the first column at initiation, you could see some number of those that has something that didn't mature yet. Somebody figured it out, but was a little bit too late. But there's a lot of number of those that actually nobody even thought of putting anything for them. And this issue is frustrating because we didn't improve. In the US, there was just no improvement. The number of people starting on catheters really didn't improve. This is a depressive table. I'm not sure why it keeps doing that to me. I'm sorry. But this table, oh, I know why. It's by touch. So this table is very depressive because when you look at the top line on the left, a man or a woman whose age is 40 to 44, the lifespan on dialysis is around 10 years. So this person is going to die at age 50s. That's the average. So they don't last that long. And as you go older, you could see their survival on dialysis is almost none. 2 years, 3 years, 4 years, very, very small, very short time. And obviously transplant reversed that significantly. So the person would live almost till the full potential. So to me, we should not have any dialysis if we can. If we can transplant everyone, then we're doing a good job. And that would probably be a good thing to think of. I want to jump back into our area of expertise or area of business where infections, enough with the epidemiology. When we say access infection, we mean the dialysis tunnel catheter, temporary non-tunnel catheter, AV fistula, or AV graft. And we know that the overwhelming majority of those are actually catheter-related infections. So we know that the risk for infection in fistula is there. It's not zero. But in 1 year, the risk of fistula is almost 1/10 of the risk if you have a catheter. So imagine you have a tunnel dialysis catheter and you dialyze for a year, you're almost 60 or 70% chance that you're not going to continue or end this year without having a bacteremia or infection. And by the way, the older data from the early dialysis showed if you had bacteremia even once, your mortality is increased forever. So it doesn't really go down to the normal. Once you get bacteremia once, it's almost like you raise your mortality rate significantly. Now, this second point is something that I'm very passionate about, and it's extremely important. And I know we as physicians may not be the one who's doing it every day, but it's worth telling people, teaching them, making sure that we act as educator or trainer. So the majority of the infection in tunnel catheter is related to the lumen. So that means if you do not scrub the hub, if you do not clean the end of the catheter, this is exactly how you allow the bacteria to go in to infect those patients. While exit site is where the catheter comes out of the skin, we know that the tunnel catheter, when they put it in the vein, they don't really get it out in the skin at the same exact site. They put it out farther. And actually, I don't know how common the practice of tunnel catheters in Egypt, but that's the standard here. And I bet things change, and I'm just not catching up. And there is a controversy around that, and I'm not sure if you guys feel that, but I would be very interested in listening to your thoughts about if you have an infected AV graft and you disconnect it from the circulation, do you have to remove it or not? My style is no, we don't have to, unless it looks infected and behave like an abscess. But the overwhelming majority of the time, they just disconnect it and leave it there. Now, we know that dialysis patients do not do as well. So let's say a 30 or 40 or 50-year-old gentleman who is not on dialysis had Staph aureus bacteremia for whatever reason, let's say diabetic foot infection, they will improve quicker, and with even shorter treatment, they will have less recurrence, less severe, less mortality. While dialysis patient, as if it's almost like a bad prototype where they just don't get better. They require longer therapy, and their complication rate is much higher, and the recurrence as well. So we tend to really treat them very long. Now, everybody would say, well, the reason for infection is still there, the dialysis. So every week, somebody pokes their fistula or graft or line 3 times, and that probably keep continuing the issue. Now, Staph aureus is the most common pathogen for all the bacteria. We know that. Or BSI is bloodstream infection. Or Staph aureus bacteremia, SAB, can lead to severe complication. We definitely know that. That's not where I'm gonna spend my time talking about endocarditis, osteomyelitis, septic arthritis, different abscesses everywhere. We know that this complication is really higher in those patients. And for sure, we know that MRSA is even worse than MSSA. And this particular paper showed this issue about the MRSA versus the MSA specifically. And Dr. Fowler, the last one, is one of the major names in endocarditis literature and Staph aureus bacteremia in the country. Now, this may be interesting for some of you. I'm not going to say it's controversial or not. I'm going to say we got to think about this too. So we start patient on dialysis via catheter. This catheter will be ultimately colonized. We kind of almost know that. So the question here is, if the catheter, like in this inside here, there's bacteria there, then every time I'm going to start dialysis, I'm probably going to push this bacteria into the bloodstream. And that makes more sense that these people will end up with infection. So how can I prevent that? Is there anything I can do to prevent that? So this particular picture on the lower right corner here, you could see this little device, and with the blue cap. So this is, give me 1 second here. Not moving free. Yeah, this blue cap here has chlorhexidine, a disinfectant, and that goes into the dialysis catheter. And you finish your dialysis, you put this cap, and that keeps this infection high level into the hub, preventing the bacterial colonization. Is that good idea, bad idea? There was a big NIH trial, and the major companies that do the dialysis in the US, Fresenius, and I don't remember, I'm blinking on the second name, but it doesn't matter. These 2 companies pretty much started using this kind of cap and showed in some clinical trials that overall, the long term, there is reduction in the bacteremia. But in my mind, it doesn't matter if you have this expensive cap or not. This has, oh, there's no voice. Can you hear me? Oh, good, okay.
تمام صوتك دكتور محمد شغال كويس.
Okay, good. I saw something on the chat, and this is why I was, yeah. When we practice medicine or seeing patient, we probably should tell the nurse or tell somebody before you do anything, you got to make sure that this cap is disinfected with alcohol or chlorhexidine very well from the outside at least. So if I don't have this expensive fancy cap, I want to make sure that nothing dirty goes into the lumen. Now, can we do indwelling alcohol, citrate, some sort of disinfection or antibiotic, which is typically vancomycin, gentamicin plus heparin, to fill this lock therapy? So you can see the lock here. So this lock disconnects the catheter hub from the circulation below. So actually, after I end my dialysis, I can fill this space with something. Would this work? It does work. Most of the people don't do it routinely. Most of the people do it when you have an infection before, or you treated an infection and you're worried that the patient will have another one, or you treated an infection but you couldn't remove the catheter for whatever reason. So then we start thinking about the disinfectant or the antibiotic lock therapy. And I don't see this as a trivial or small issue. I do really think there's a lot to do with this. We're running a study at the University of Pittsburgh currently to try to study the luminal fluid in the catheter in the people who have this particular cap or do not, and try to link that to the presence or absence of bacteremia after. I don't have the data yet, but we will update you for sure maybe in the future. Now, this issue here for the coming few pictures and slides, I bet you guys are not that familiar with, and I'm not sure if even a lot of infectious disease doctors are or not. But our city water in Pittsburgh has a lot of bacteria. And this plate you have in front of you is called TSA plate. And you have a filter membrane, Nalgene filter, and you could see these yellow colonies on it. This particular yellow colonies are actually Delphitia acetovivorans. And we have on top of that, on the right corner, you could see this kind of study from the NIH on Sphingomonas. And probably some of you heard about Stenotrophomonas or Achromobacter. There's a lot of waterborne pathogen, and this gram-negative predominant pathogens cause a lot of problems with dialysis. And this is why we do a lot of things for dialysis water to make sure it's a little bit better than what we drink from the faucets. And if I don't like the water in the US, I'm not going to say anything negative about Egypt, but I would say probably the water in Egypt is not much better, if not any worse. So we really need, as infectious disease doctors, to think about this. Where do this patient have their dialysis? What kind of water treatment they have? What do they do? So in general, any dialysis patient in the US, they have to have, any dialysis center, not patient, I'm sorry, they have to have water culture sent every month from the machines, from the reverse osmosis or RO machines, and they have to have an endotoxin assay every month. And there is specific guidelines about the colony count on this particular TSA plate without the filter, and endotoxin level that they should be below that level. We understand that the water may have something, but it should be to an extremely low level. Once it gets to a higher level, we do something called action level, where the machine has to be disinfected. And if the level is so high, the machine has to be taken out of service, sanitized, disinfected before it is actually used again. This is extremely important for safety for the patient. You see on the lower right corner, this is an additional filter that some of the dialysis centers even have, and that is connected to the dialysis machine. But let me take you back one more step here. So on your right-hand side, you see this is what we call the central RO. So the reverse osmosis is a very simple way to purify the water. And you can actually generate a lot of water from this, that it's actually high level water with almost no contamination, no bacteria. And in my mind, that's almost like a must for dialysis centers. If you don't have that infrastructure like a central RO, you probably should have at least the portable ones, and I'm going to show it to you. But on the left side, this is what we call the dialysis box. The connector for the water has to be kept clean and tidy. And there was recent outbreaks of gram-negative bacteria and infection in dialysis patients reported by the Morbidity Mortality Weekly Reviews and the CDC from contamination from these dialysis boxes. So we got to be very careful with the water when we're talking about dialysis for sure. So this picture here, this picture here shows you, this is what we call heat RO or reverse osmosis. This is a portable one. So you can take that into the patient room, or it doesn't have to be in the same spot. But you probably could use it in dialysis center too. And this is the older fashioned, what we call the chemical disinfection machine. But in general, you see blue and white filters. So these are the large membranes. Oh my God. These are the large membrane, and this here is the carbon filters. And those 4 filters pretty much purify the water before it goes into the dialysis machine. And this is the additional filter that I was telling you about here in the picture. So this actually goes into the dialysis machine straight. Now you could see those membranes, how dirty and brown looking. And this is actually Pittsburgh picture. That's not from anywhere else. What I'm trying to say here is the water has tons of sediment, tons of stuff that is not supposed to be there. And at some point of time, you're going to overwhelm these membranes, and the machine that is supposed to clean the water would not be able to do it. It will do it to a limit. So what we did is actually in our dialysis center, we applied those filters, and you could see in front of you a partial or small piece of a filter and another one here. These massive filters takes all incoming water to the dialysis through these 2 filters. The first one that you don't see very well is 4.5 micron. So that takes all the sediments, all the big particles. And then those big filters are relatively cheap, while the 0.45 micron traps almost all the bacteria, but it could actually slow the flow, which is pretty bad for dialysis. So the 2-step filtration, in my opinion, is probably the smartest way to make this as safe as possible. And you can easily see the picture difference between the plates on your left before and on your right after. No single bacteria on the membrane, too numerous to count bacteria on the left before the filter. So I'm asking you to think about this for your dialysis patient. And if any of you is involved in infection prevention, you probably should go visit these places and ask questions and see what they're doing. Now, we had a talk about an outbreak of carbapenem-resistant NDM strains. And one of the data that one of my colleagues was presenting, showing that NDM, the countries that has a lot of NDM, the map has Egypt listed as one of those. Obviously, that's not fun. That's not a good thing to be proud of. But I'm saying I know for sure from some data that this bacteria is everywhere, including Egypt and others. So to make the story short, if I describe to you a person who's weak with lower immunity, having multiple infection, having an indwelling catheter, has to go to the hospital repeatedly, gets a lot of antibiotic for different infections, you're probably going to say, well, that patient would be heavily colonized. And that is absolutely true. So dialysis patient, end-stage renal disease patient are really higher likelihood, have higher likelihood to be colonized or infected with multi-drug resistant organism or MDROs. So the causes are self-explanatory. We understand that. Now, vancomycin intermediate Staph aureus or vancomycin resistant Staph aureus. So the VISA or the vancomycin intermediate is there. I mean, we've seen few cases, and probably hundreds in the US. The Versa still remains very rare, or vancomycin totally resistant, and it has to do with the MICs for the vancomycin. But if you look at the original natural history or the original reports, almost all of those patients were actually dialysis. Almost all those patients were colonized with vancomycin-resistant enterococcus or VRE and had some sort of infection with Staph aureus, and they developed these freaky strains of ultra-resistant Staph aureus. What I'm trying to say is expect the worst when we're dealing with dialysis patient. Make sure you try to get some maybe surveillance culture. If you're thinking somebody has a sepsis and you don't know where it's coming from, maybe the skin, maybe the urine, maybe others. I understand that you don't have to treat colonization, but maybe that would help you to understand what is going on. Maybe that would help you to even prevent this infection from spreading to others and so on. The same for the carbapenem-resistant organism, CRO, or carbapenem-resistant Enterobacteriaceae, or Enterobacterialis to be the new names. We know about the vancomycin-resistant enterococcus and MRSA colonization from before. I just want to make one note on the hospital-associated infection real quick here. So pneumonia is increased in dialysis patients and end-stage renal disease. My point to take here is, I understand that, but in reality, I also see it overcalled, and I will be very interested in listening to your thoughts. But a lot of patients on dialysis, they come to the hospital short of breath, have some cough, and everyone says, oh, they have a pneumonia. And you look at their chest x-ray and say, yeah, it could be pneumonia, but I do think it's actually fluid overload. And next day, or the day after when they finish the dialysis, you repeat the imaging, and it looks almost normal. So you know that was not a pneumonia. So I think pneumonia diagnosis in those patients is hard, and I think we cannot afford not to treat. But I would say if you do not think in retrospect that that was a pneumonia, you probably should stop the antibiotics in 48 to 72 hours. If you said, you know what, this, yeah, we thought it's pneumonia, but actually it totally, there's no pneumonia that the chest x-ray will clear in 2 days. So maybe that would be something to think of. Urinary tract infection is also extremely overdiagnosed, in my opinion, in dialysis patients. We do believe that anybody could get urinary tract infection, but the risk for UTI in those patients are much lower than almost anybody else. For that reason, we know that you get a urine sample from a dialysis patient, this urine sample could be actually 1 day old. So if they have theoretically 2 bacteria in their urine per maybe millimeter, this number could be infinite time increased within 1 day. So what I'm trying to say here is urine culture positive is not equal to a UTI or urinary tract infection in those patients. Finally, nobody would argue that these patients have more bacteremia than anybody else. And that's what we focused on initially. So then this takes us back to what can we do? We talked about the catheters briefly, the cap, the scrub, the hub. We talked about just stop dialysis totally and go for transplant, or even do the lock therapy for whatever way. Then if I told you that all these patients were colonized with heavy colonization, maybe you should think about decolonizing those patients as well. And I put this paper in front of you with Susan Huang as the senior author, and all these names are very big names in this area. This study called the CLEAR study, and pretty much give those patients with high risk or diagnosed with MRSA oral mouth wash with a very low level chlorhexidine, bathing with chlorhexidine 5 days every 2 weeks for 6 months, and give them mupersin in their nose. And that showed reduction for over a year of MRSA and MSSA, so Staph aureus bacteremia infection, surgical site infection, and even clearing their colonization as well. I do think there's a room for practicing this decolonization. If I can't help those patients, if I don't think they have an infection, I probably should aim at decolonizing either all of them or some of them. we have to think about this. Now, who's going to do that? If I am an infectious disease doctor and I don't see all those patients, they're probably going to be your nephrology colleagues, or who are actually seeing those patients regularly, maybe talking to them. This kind of data could help them to think about doing that for their patient. They could do their culture to prove that they're colonized, and they could do whatever is appropriate if they are. I'm moving quick, but just for the sake of the time, and I really want to hope to have a few minutes to discuss and interact. And I think that will be even more important than anything I'm saying here. But Clostridioides difficile infection, CDI, again, I'm repeating myself. We know that those patients takes tons of antibiotic for whatever reason, and they are more likely to get C. diff than an average person. So their incidence and prevalence is higher, but also their severity, because their immune suppression is higher, and the recurrence for C. diff is actually higher among those population. Now, we know that the rate for colectomy in those patients is even higher than the average population, with an odds ratio, OR odds ratio of around 2.3. So the risk is really significantly higher as compared to non-dialysis patients. But the treatment is not any different. So we treat those the same. So if you think you're going to use fidaxomicin or vancomycin orally, that would be fine. Guidelines probably reduce the metronidazole as less preferred. So I'm not sure if I would be using metronidazole in those patients. Maybe an adjunct to others, but not the main therapy. Now, TB. So I still remember this TB review article from the New England Journal of Medicine, maybe 6 or 7 years ago now, talking about who should be screened for TB. And among those, they put the people who have higher risk, among those who have actually end-stage renal disease and dialysis patients. So we know that if you're in dialysis, your risk for infection for TB is higher. We know that if you have, excuse me for a second. We know that if you have a transplant, or you become a transplant recipient, you take a lot of immune suppression, so that also doesn't help. So we know that if you are end-stage renal disease, you're probably going to have a higher risk for TB. So what does this mean? Means I got to think of TB in this population. I got to have it somewhere in my mind when I see something in their chest. I'm not going to say, yeah, I don't think so. No, I'm going to think that could be the case. Now, in the US, more than in Egypt, we depend heavily on latent TB screening. We do skin testing, we do blood for interferon gamma release assay, IGRA, and we pretty much try to rule out TB or latent TB in those patients, not open TB, but latent TB in all the dialysis patients. But we all understand that the response and the validity in dialysis patient for these testing, both of them, is not great. I would say any positive induration with skin test, I put here more than 5 millimeter. If you see any induration, consider it positive, even if it's less than 5. The discussion about the adenosine deaminase is endless, but I would say probably it would be helpful for acidic or pleural fluid, but not much anywhere else. And I would say it's helpful when it's high to think more, but it doesn't confirm. And if it's low, I don't think it rules it out. So it's one of these tests that feel good tests, like you do it, you feel better about it. But in reality, I'm not sure how much it should change your mind. We do the PCR for tuberculosis after a positive stain. So we do the acid-fast stain. If it's positive, we run the PCR on the specimen, but we don't run it on every case. I still think a tissue biopsy, fluid, liquid, sent for histology and culture is probably the best way to diagnose TB, and that would be an open active TB. And it depends how do you confirm TB, by using the MALDI-TOF or using a DNA probes. That's probably institution difference. The main message here in this slide is TB is definitely way more common in dialysis patient, in stage renal disease, even transplant, and we got to think of that. Now, this is a trouble slide for me, and I'm not going to even go in a lot of details with it, because I really want to emphasize that if you think of any vaccine, please do it as early as you can. So do it before the patient goes into dialysis. So your diabetic patients who have creatinine of 1.5, 1.6, make sure you check their hepatitis B surface antibody. And if it's low, vaccinate them. This is their best chance to get immunity, rather than when they go for dialysis, the response is going to be low. And that applies to all the vaccination in general, not specifically, but we know historically, like 30, 40 years ago, when people would start in dialysis, almost 100% of them would have hepatitis B. And that's a main reason for the liver failure and death. This improved after the hepatitis B recombinant DNA vaccination. That was probably in the 90s. And the number of hepatitis B, and I know in Egypt this is a small number, it's not high, and the same here in the US, but hep C is much higher in both places as far as I know. So we gotta put this in our mind that dialysis is a very bloody procedure. We poke things, we get blood samples, we get blood cultures, we move things. There's a lot of blood everywhere, so we gotta be very careful. One of the major issues we learned in dialysis was related to the multi-use vials, where people would have a large bottle that has heparin or has whatever medicine, and you poke the vial, and you take sample. You could take some, give it to the first patient, move the same vial into the second and third and fourth. We stopped that totally, and I understand that that could be expensive. But if you're sharing anything between patients, you got to be extremely careful. It doesn't take much for bloodborne pathogen, HIV, hepatitis B and C, to spread among dialysis patients. So I would say be very, very careful with that. And obviously vaccination and having immune antibodies to hepatitis B, for example, is one of the best ways to prevent that person from getting the harm. I think I was ahead of myself and I talked about that as well. I think this is my last slide, and I'm actually very happy that I'm finishing almost on time. So I am not going to talk much about this, but I think that's also extremely important to consider. So dialysis patient coming to the hospital, infectious diseases consulted, or even the medicine or the emergency medicine or whoever's seen the patient first, they tend to give a lot of antibiotics. And somehow, when we see the patient as infectious diseases, we have different opinions almost all the time. And I'm not sure if we're just difficult people or we think different than the general interest person. I do think it is the second one. So in my mind, rule number one, if you think your patient is sick, forget about renal dosing. Just give them as big dose as you can. So if you think the patient is going to die from sepsis, going to the ICU, I'm not going to underdose. I'm going to make sure that I'm dosing or overdosing, not underdosing. And I know and I understand that this could have some harms. I get it. But in the meantime, most of the discussion about renal clearance is on the steady state, means you keep the level super high for quite some time. But if you give a smaller dose of antibiotic for somebody who's ill or sick or septic, you're probably going to have a high risk for mortality with that. So I would say dose and don't worry about it for now. Loading even for vancomycin is not a bad idea. So even if I give the first dose as 2 grams in a dialysis patient, that's not a crime. I know this sounds like a very high dose for a dialysis patient, but it's probably okay. You can check the level after, you can redose whenever you think is needed, but you really cannot afford to have an underdosing for those patients who are very sick. Conventional dialysis is relatively easier to understand. But what is not easy to understand is the people who have different types of dialysis, like continuous renal, like CRRT, people who have 4 hours of dialysis at night every day, people who have peritoneal dialysis. There's a lot of different types that is less common. But the conventional dialysis, we have reasonable data, we have books, we have tables, we can actually check and see what is the dose we need. But be very careful with the continuous dialysis patient. So typically, a person in ICU, you cannot put them in dialysis because the blood pressure goes way down. So you put them in a very low perfusion or exchange to take the fluid over 24 hours or more. I would say the simple rule for those is you remove 30% of the dosing. So if the dose for cefepime 2 grams every 8 hours in a normal kidney, so for CRRT, we'll give 2 grams every 12 hours. But for conventional dialysis, we give them 1 gram every day or 2 grams. Maybe some people would not agree with that, but 2 grams after every dialysis. So what I'm trying to get to is if your patient is very sick and if you are in doubt, give the bigger dose, readjust later. If you have a regular type of conventional dialysis, look up the information and you should be right. If you don't know very well about this because there's not much information, ask for all the help you can get from your pharmacy, from your nephrology colleagues. Do your best guess, see if you can send levels. I think it's very important, but don't worry about the first dose, just do it the first thing first. I think I covered most of what I can cover as fast as I can, and I am really interested in hearing your thoughts and input. Thank you so much.
شكرا جزيلا دكتور محمد. احنا يعني
عفوا.
محاضرة جميلة واستفدنا جدا بحضرتك يعني.